Good morning. Today we'll be talking about antimicrobial resistance. Thank you, Dr. Opawoye and pharmacist Lawal, for both coming on the program to discuss this important topic. If I can kick off with you, Dr. Opawoye, can you talk to us about what is antimicrobial resistance? Just to explain it medically and say how it happens.
Okay, thank you very much, Dr. Pamela, for that beautiful question. I think where we'll probably start from is defining what antimicrobials mean. And antimicrobials are basically drugs that we use to counter infections, which may be bacteria. That time we call it antibiotics. It may be viral. We call it antiviral. Maybe fungal. We call it antifungals, or it may be against parasitic agents, or antimalarials or whatever. But antimicrobial is something that's just so when we talk about antimicrobial resistance, all of a sudden the drugs are not working that used to work for a particular infection before are not working anymore. That's just a very simple term. So meaning that at some point a particular drug works against an infection. Once you take it, you're good. And then because of the adaptability of the bacteria or the fungi or whatever organism it is, now when you take it, it doesn't work anymore. So give you an example. There was a time we used to use a lot of chloroquine for malaria. That was the go-to drug when I was younger. 30 years ago, that's what we used, chloroquine and energy. You take those injections, your buttocks, you'll not be able to walk for some days, even after the malaria has gone. And then all of a sudden, chloroquine stopped working, it's going to be very rare for you to see chloroquine being used now, except for some very recalcitrant people who just don't want to move on from it, So that's in a nutshell what antimicrobial resistance is all about. It used to work before, it stopped working, majorly because of overuse. Thank you very much.
Okay, so what makes it stop working?
Yeah, so
what makes these so you've talked about antibiotics. People know antibiotics. People know antiparasitic agents, like obviously the antimalarial. Those are the common ones that we use in our environment. So, as you mentioned, chloroquine was used. Chloroquine has suddenly stopped working. Why?
Okay, so basically, it's all about survival, and everybody adapts. If you don't adapt, you'll die. If you look at the situation of the country, for example, it's been quite funny economically, but we are here because we have adapted to the situation. So just about a year ago, we're buying fuel for about 184 naira. Now we're buying it at almost 10 times the price, but we're still driving our cars. We're still going to work somehow because we've survived. So all organisms adapt. They evolve to survive. That's why we're still here. If you do not survive, you can't. So for example, if you're looking at that analogy, you find someone who was in Lagos and then all of a sudden, because of the economic situation, has to move back to the village. That person is not adapting well to the new realities. So what happens with organisms is that they also adapt. Once you're trying to kill them, they're also trying to dodge you. And so with constant exposure to an antibiotic, they develop all sorts of mechanisms to evade that particular antibiotic. And so in the course of time, the antibiotic will stop working. That's just how it is.
Okay. And so if I can then ask you, why, just for people who are listening, why do people use these antibiotics and all different kinds of drugs? They're prescribed by doctors. How and why are they used?
Well,
or should I ask the pharmacist?
Well,
You're the one prescribing.
Yeah, we prescribe, they give it out at the end of the day, so it's a two-man job. It's a teamwork.
So you speak first, then she'll speak afterwards.
Yeah, I think the thing is, we all want to get better when we're sick. That's the truth, if you're sick, you want to get better, and you will do anything to get better, most of the time, So whatever you think would work, you will take it, whether it is prescribed or not, and that's the problem, So at the end of the day, we end up sometimes by using these medications, even for things that are indicated, So, for example, I had a patient about last month who has been treating malaria every month for the past 30 years. That's just impossible. It's totally that's not malaria. It's not possible. Totally impossible, But this was.
Thank you for asking me that question. It's a big burden to me like doctors said, so many people use antimicrobials just because they think that is what they need to get better, because everybody wants to survive one way or the other. And many times we find cases of self-medication or wrong diagnosis. They have some symptoms. A number of people still diagnose whatever is wrong with them based on symptoms, and then they assume that this is what is wrong. Then they run after. In Nigeria, anti-malarials are over the counter. So they have free access to anti-malarials. You find, like the example Dr. gave, is not unique. There's so many examples we have found in practice like that. I've come across somebody who was always treating malaria and typhoid until we stepped in and helped him to the right place for treatment. And then he was found out to have hepatitis. And since his hepatitis got attention, for many years he had not taken any anti-malaria. So we have many cases like that in the environment. And there are many drivers,
unfortunately. So, Dr. Opawoye, can you tell us why do you think that people do this? What is it about our environment that has really led to this huge burden that we have with antimicrobial resistance?
Well, I think there are so many factors, because a lot of times when we're looking at antimicrobial resistance, we are trying to look at what we call the One Health approach. You're looking at human health, animal health, and also environmental health. While a lot of times, we talk about human health, the antimicrobial use in animals is crazy. I mean, every poultry farmer, they use tons of antibiotics, tons of antibiotics. They get tetracycline in sacks, huge sacks, and they pour it into the feed and they tell you that's what keeps the animal strong. And so by the time you are eating that chicken, I mean, you're taking all sorts of things. So it's really multifactorial. But for me, at the end of the day, when you're looking at this part of the world, we have very weak regulations, and unfortunately, it's because of our people. So we don't have a lot of healthcare practitioners in Nigeria, right? And even the few number we've had, there's been a massive exodus over the last few years, So, and then you're trying to reduce the barrier and access to medications to say that, okay, look, instead of saying that every prescription must come through a doctor, as is done in most developed countries, why not let us reduce the threshold? Let people be able to get what they need as soon as possible without having to go through that way. It will save some lives. But then it's now being taken to the extreme where people totally eschew the services of trained professionals like doctors, like nurses, like pharmacists, and they just bypass all that and then they go and take medications by themselves because they feel. And the challenge, like pharmacists said, is that many times these people have more devastating diagnosis that I mean, we've had people who were treating malaria for months. At the end of the day, we discovered they had a malignancy, they had a cancer, which if it had been detected earlier, would have had better results, So that thing of skipping the process, and also their finances too do not help. Now, look at case in point. To do a malaria test in this country will cost you an average of about maybe 2,000 to 5,000 naira. To buy whatever loan that can be as cheap as 600 naira. So you ask me which one you would go for if you are faced with that dilemma, because if you do the test and it is positive, then you have to go and pay for the drug again, or you just buy the drugs directly instead of having to go through do the test, So the economics are also a bit challenging in terms of.
But it's a false economy. It's a false economy.
I agree with you. I agree with you on that because the deleterious effects are not felt in the immediate; they are felt later. You understand? But that's the reality at what is happening now. So, for example, when you take it a bit further, you want to do a blood culture for a patient to be able to make a diagnosis. Blood cultures cost you about 20,000 naira, and then the patient is wondering why not just buy antibiotics with it, instead of going through the test. So those are the challenges that we face, but. Many of these things can just be said is because we are thinking in the short term. We're not looking at the long run. We're not looking at the problems that this causes. As an infectious disease physician, many times you call to bedside of patients that literally when you see their blood culture result, Sometimes you almost just write a death certificate because you know there's no way. I mean, they are resistant to every single antibiotic. There's no way. This person cannot survive. And very basic infections. And it's because they have been exposed either directly by themselves or through the environment because of their consumption. They have been exposed repeatedly over time. So it's a big issue that we are facing now. We used to think it was not our problem, because we don't measure this thing. So what's not measured is not seen. But then when we started tracking it, when we started measuring it, we discovered a lot of people coming with very simple infections. It's just a simple cough. And then the next thing, the thing will go and then you start growing terrible organisms, and then you wonder what exactly is going on. So it's a big problem now, and we really have to educate our people more on how to prevent that.
Thank you very much. Thank you. I think, Dr. Opawoye, if we can just, we had a discussion during the break, and, people are concerned about this issue to do with, using of drugs and the malaria typhoid issue, that being obviously a concern and misconception. But from your perspective, how do we address this issue and prevent it? How do we, deal with this matter that people are really just using drugs anyhow?
Thank you very much, Dr. Ajayi. So I think it's a multi-pronged approach, but it has to start from the individual. We have to educate people, which is what we are trying to do here. Let people know that they should be properly diagnosed. Not all fever is malaria. Not all fever is typhoid. Malaria and typhoid is almost impossible. It almost never occurs. And that fever may be it may be nothing. Sometimes all you need is just rest from all the stress on all the travails and the economy. Just rest and everything goes away. Sometimes it may be a viral infection that will not respond to any antibiotics. You take nothing, you go after 2-3 days. And then sometimes it may be something far more sinister. It may be infective endocarditis, which is an infection of the heart valve. It may be something very serious. So anytime you're feeling unwell, get to the hospital. We have telemedicine platforms now to be able to actually speak to someone. Don't just call that. Because a lot of times, the challenge is that people need to understand from that aspect. And people need to ask questions before you take an antibiotics. Ask why. When someone is prescribing antibiotics to you, why am I taking this? What's the reason? There's always a reason for antibiotics. There's always a close date for antibiotics. You don't take antibiotics for 3-4 weeks for no reason. Why am I treating malaria every month? You should ask these questions. So we'll start from the people, and then we'll go to the providers, especially the pharmacists here. Pharmacists are a big problem, when it comes to, we will not due respect when it comes to antimicrobial resistance, because it's what they sell. So you're hitting at their profit end sometimes when you're telling them to reduce the sales of drugs. Now we have a lot of pharmacists that have nothing more than salespersons at the counter. And these salespersons are trained to increase the types and complexity of drugs that a patient comes to collect. So somebody comes into the hospital sometimes with a prescription. You give a patient a prescription for Ampiclox. And they come in and say, oh no, why are you using Ampiclox? We can use cefepime. Like how? From Ampiclox to cefepime, I mean, that's a huge job because cefepime is far more expensive than Ampiclox. You encourage the patient and you convince this person that doesn't know much to say, oh, look, this one is better. Don't worry, it's stronger, it works faster, and then give them something they don't need because of the endpoint. And then we have some of these people come in and says, okay, but when was the last time you treated malaria? Oh yeah, treat malaria. Oh yeah, take some folic acid, take some vitamin C. And at the end of the day, the person leaves the pharmacy spending 100,000 when actually there was nothing wrong. So I think there has to be a lot of regulation from the pharmacies where it has to be controlled as to making sure that antibiotics are actually prescribed. We have some that can be OTC, but most of them are not over the counter. And then also making sure that people actually get, because many people in this country go straight to pharmacists. They don't even come to the hospital at all. They go to pharmacies, and except you find a very good pharmacy, most pharmacies they are manned by people who are literally sometimes just coming from the village. They have not been to a lick of school. They don't know anything. And then they keep confusing people and giving them things that they do not need. So we really need the pharmacists to join us in this fight. Sometimes big pharma does not help. So I had a situation where the makers of meropenem came into, they were like, oh, they are doing antimicrobial stewardship. And then immediately after that lecture, they came to say, oh, we are reducing access to meropenem. Now meropenem is cheaper. I'm like, guys, how? I thought you didn't want us to use this. And then, I mean, what are you doing? What are you doing? And I called them out on it. And they were like, oh, no, we are saying that the people that need it should get it. But I said, look, once you reduce the barrier to access, then even people that don't need it will get it. And it became a big problem. So big pharma needs to help. But like I said, it's a bit difficult for the pharmacist here because it's like you're asking the fox to guard the end cup, So that's the challenge with them. But until we tackle it from these two ends, and for pharmacists, it doesn't pay them to invest in development of antibiotics because, like I told you, antimicrobial resistance is inevitable. What we try to do is to slow the progression. It will always happen. So antibiotics is something you want to use 3 days, sometimes 5 days, sometimes 2 weeks, and you stop. Maximum is do sometimes for very sick people. We do 6 weeks, 8 weeks, and then stop. Antihypertensives are taken for a lifetime. Anti-diabetics are taken for life. So it does not pay them to do R&D into development of antibiotics. And that's what we are seeing now. So that no new antibiotic has really been developed in almost 15, 20 years. That's the challenge. We're just rehashing the old ones that we have. So in summary, we need our people to ask questions. When you are getting antibiotics, ask, why am I taking this antibiotic? If you are treating malaria every month and you have been a full-blooded Nigeria, your blood should be resistant to malaria by this point as an adult. So if you are treating malaria all the time, there's a problem. It is something else. You can never have malaria and typhoid. Try and investigate. Try and get this stage done. What exactly is going on with me? When people give you drugs, ask questions. And then, because a lot of times we also face pressure from the patients. The patients insist, doctor, no antibiotic care. But Chama, I had a situation where a mother brought a child to me that the child was the stomach was growling, and I spent almost 30 minutes explaining that the intestines were growing. I gave her my stethoscope, listened to it. Everybody's stomach is making noise. We call it bubble breathing in medicine, blah, blah, blah. And after that time.
No, I want to just ask, because you see, you can't just blanket, because it works, cast everybody with a, brush. And that's why I'm asking Pharmacist Lawal. How, for example, if tomorrow he goes into such a pharmacy and this man is confronting him and he thinks he's a businessman, even our own doctor, how does he tell whether it's a real pharmacist or not a pharmacist? You yourself said before, there's a dearth of pharmacists. We don't have enough pharmacists. The Ajapa syndrome has taken away a lot of our people, doctors, pharmacists, nurses, everybody. How do we tell who is the pharmacist in a pharmacy or not?
When you are inside the pharmacy, you mean, or from the outside?
Yes, when you have just come in, you're looking for medication. How does the layman or even the doctor who is saying that these are not pharmacists, how do they tell?
Many pharmacists, some of them use their lab coats. They have name tags, and you could ask to see the pharmacist. By the time you are discussing with this person, you should have an idea if this person is a pharmacist or not, because you must ask questions. Like doctor said, somebody is telling you to take this. You ask questions around it. And the confidence with which the person answers you should give you an idea. If you're in doubt, don't stay there. If you're in doubt, go to where you are sure of. So you can ask questions. This medication, what is it for? Why am I using it? How do I take it? You ask questions. Okay. So that will give you a clue.
Okay, so thank you.
But more importantly, we need that the regulators sit up and regulate the practice, every practice, because there are also there are fake in every profession. There are fake professionals here and there.
Yes.
So you could also go to the hospital and see a fake doctor. So you should be on the alert. You should look out. You should ask questions. We need the regulators being more active than they are. And then probably here, though we're talking about faking now or identifying who the real professionals are, but there's also something very important that we need to look at with that of healthcare professionals. There's a need for task shifting. There's a need for more virtual things being done, virtual consultations for ailments that can be managed virtually. And we need more collaboration. We need to work together as healthcare professionals. We should have easy access to one another.
That's important. So going back to antimicrobial resistance, I think it's important that you tell us how you as a pharmacist are doing. What are you doing to prevent it or to reduce its occurrence?
Okay, one of the key things that I believe in is the best thing. Let's even prevent the need for the antimicrobial. as much as possible. Because like doctor said, for as long as we use it, someday there's likely to be resistance developed. So how can we ensure that we reduce the need for antimicrobials? And we are talking of infections here. Simple hygiene, simple washing your hands. When Ebola came, people almost took their bath with hand sanitizers. The moment it went away, hand sanitizers started expiring on our shelves. That's one area that we need to look at. Clean your hands simply by cleaning hands. I read an article some time ago, a WHO article, that the deaths from diarrhea in children under 5 was reduced by as much as 30% in this country just by washing hands. So let's maintain hygiene, clean potable water. Let us also prevent preventable diseases with vaccines. There are vaccine preventable diseases. So let's look at the prevention first. We're talking of malaria here now. No mosquito, no malaria. So what can you do to protect yourself from mosquitoes? Can you keep mosquitoes away from your house? If they get in, can you protect yourself from getting bitten? These are the areas that we need to look at, and a lot of education has to be done here. So we do a lot of patient education counseling. The moment a patient is coming down with a particular condition, we want to help him to identify what he can do to prevent a reoccurrence. So like I said, patient education. And for antimicrobial resistance, one key driver is misuse. So it's important that we help the patients get the right diagnosis. And when the right diagnosis is in place and there's a prescription, we guide the patient as to use. So daily does not mean just anyhow, you take in the morning today, tomorrow you are taking in the evening or afternoon. No, daily means every 24 hours.
Okay, thank you.
And that is very key, very important. I've seen a patient take anti-malaria that was meant to be daily, took on Tuesday night, and then took the next dose Wednesday morning. And because it was amodiaquine, this woman was really thrown out because there was a lot of overdose there. So we want them to know that this has to be.
That is scary drug.
Yeah.
Amodiaquine is scary.
So I think that's great. I think that's important. But we're gonna have to wrap up soon now. So Dr. Opawoye, do you have anything you'd like to add to this?
I think Pharmacist Lawal has said a lot of very important things. It starts from regulation. And I think for the regulation, we need to start applying pressure from the healthcare workers. We know the danger here. We need to start applying pressure on the government to cut the access. We have too much access. And now we all know that a lot of times when we travel out of this country, most people will tell you, pack your drugs along. You are packing your Coartem and your diclofenac and your Fasda, whatever, and your Augmentin, you pack it in your box because you know that if anything happens to you in the UK or US, you're in trouble. Now, one vial of artesunate in the US is close to $30,000. The pharmacist knows the price here. One vial of artesunate, same drug, So, but it's because the access is really reduced there, and it helps. Now, like I said, it's a balance, and we have tilted too far on the other side. I mean, we're not talking about drugs of abuse today. I've been there in pharmacies where people collected pounds of codeine from pharmacies. Bad pharmacies supplying patients with cartons of pentazocine. All these drugs are restricted drugs. These are not things that you should have over the counter, but we don't have those legislation in Nigeria. And like Pharmacist Lawal has said, I mean, there are lots of pharmacies there are lots of pharmacists with pharmacies without pharmacists. That's the truth.
Thank you for watching. Please like, share, and subscribe for new video updates.